adrenal gland. As you know from the previous lectures in anatomy, that the adrenal glands is a two gland. Also, it is called the suprarenal gland. It is located above each kidney. The right one, it is triangular in shape. The left one, it is crescent shape. And also, as you know, because the presence of the liver, the left one higher than the right one, as the kidney also, it is higher. Okay. In a human, each adrenal gland weighs about 5 grams. And also, each adrenal gland composed of two parts. It is the adrenal cortex and the adrenal medulla. And each one has its function by secretion of hormones. So it is considered completely, it is the endocrine gland. So the adrenal cortex composed of 3 layers. It is the zona glomerulosa, fasciculata, and reticularis. And each one of it secretes specific hormones. The adrenal, the zona glomerulosa secrete the mineralocorticoid. The fasciculata secrete the glucocorticoid, and the reticularis secrete the androgen, or substance like androgen. So, and then the adrenal medulla secrete the epinephrine and norepinephrine. This is the introduction for the adrenal gland. So the adrenal gland, it's very important organ because it regulates the content of the body, of the control of the minerals inside the body, and also control the blood pressure and the other function. It is secrete its hormones directly to blood. So we should remember the blood supply of each adrenal gland. Its blood supply from 3 arteries. The first one, it is the direct from aorta, and branch from the renal artery, and also branch the branch from the inferior phrenic artery. So 3 arteries, the blood supply of each adrenal gland come from 3 arteries, and also the blood go outside it by 3 veins. The adrenal glands also affected by multiple type of disease, and also it lead to uncontrol or affect the control of the hormone and function of the adrenal gland. So the function of the adrenal gland, or the affected by multiple diseases, we start by dysfunction that affect the adrenal gland. Start with adrenal cortical adenoma and carcinoma. Adrenal cortical adenoma and carcinoma may non-function or function. So the importance of this disease depends on function of this tumor. So it increase the secretion of hormones or decrease. So it is hyperfunction of the adrenal gland, or dysfunction or hypofunction of the gland that lead to decrease the secretion of hormones. The most common clinical syndromes associated with functional adrenal cortical adenoma and functional carcinoma are primary hyperaldosteronism or Cushing syndrome. However, many patients also have evidence of virilization or feminization. Now, at first, 3 type of tumor, or 2 type of tumor, but at first we start with incident teloma. what I mean by incidentalloma. Incidentalloma, it is a mass or nodule that's discovered suddenly. The patient go for follow-up or go do ultrasound or whatever the imaging modality for diagnosis of other disease, and incidentally we find that the patient have a nodule of the adrenal gland. This nodule size should be less than 5 cm, so it's considered incidentalloma. Incidentalloma need follow-up by the function and its effect on the body, and also follow up by its size, if it's increased in size or not. So it is considered incidentalloma. Incidentalloma may contain carcinoma or adenoma. Okay, now we'll go for Cushing's syndrome. Cushing's syndrome is caused by excessive adrenal secretion of corticosteroid. As I said, it is secreted by the second layer of the cortex or by zona fasciculata. So it is its secretion resulting in characteristic clinical presentation of truncal obesity, impotence, gynecomastia in male, and increased bruising and cytria, hypertension, osteoporosis, peripheral extremity muscle wasting. Cushing's syndrome may be due to a pituitary adenoma, Cushing disease. It is about 70%, on an ectopic ACTH producing hormone, and the primary adrenal cortical tumor. So the patient, this is the picture, show the patient with Cushing syndrome. Cushing's syndrome. It is sometimes called the lemon body. يعني شوف جسمه انه يكون المصل مالته ويستنج ضعيفه، عند الفيس مون فيس، والبودي ترانكال اوبيزيتي، فيصيحوا له الليمون ترانك، اللي هو يعني جسمه مثل الليمونه ورجليه على كانه ستيكس، كانه يعني على عوده، على قد ما ضعيفه الليجز مالته، فهذا يسموه طبعا المود مالته او personality changes occur, moon face, okay, susceptibility to increased susceptibility to infection, gynecomastia, fat deposit on back اللي يسمونه buffalo hump، مو شباب يسمونه buffalo hump اللي هو accumulation of fat and back، يعني it appeared like the hump, and also hyperglycemia, CNS irritability, central nervous system irritability, okay, sodium and the fluid retention, and then the thin extremity, as I said, and also for female, menorrhagia, hirsutism, thin skin, purple cytria, and also bruises. So this is the picture, show the patient with Cushing syndrome. And patient with Cushing syndrome due to primary adrenal tumor, the underlying pathology may be benign adenoma, or as I said, may be adenoma or incidentalloma. Incidentalloma, if you find it suddenly and size less than 5 cm. And also maybe it caused by carcinoma. And adrenal adenoma is more likely when the size of the lesion is said less than 6 cm. And then pure Cushing syndrome is present. Treatment for Cushing disease. Cushing disease of pituitary origin treated by a transsphenoidal hypophysectomy. And also, treatment is ineffective than bilateral surgical adrenalectomy. يجينا سؤال: we can't do bilateral adrenalectomy? Yes, if the patient have a severe symptom and it not response to this surgical modality. Cushing syndrome due to primary adrenal tumor treated by surgical adrenalectomy. Clinical presentation of adrenal cortical carcinoma: 50% functioning with symptoms related to excessive adrenal cortical steroid production. 50% are non-functioning tumor, and these patients presented with non-specific symptoms such as abdominal pain, mass, fatigue, and weight loss, and treatment by surgical or complete surgical excision. Primary aldosteronism: it is a secondary cause of hypertension characterized by excessive and unregulated secretion of aldosterone. Etiology: an adrenal cortical adenoma, bilateral adrenal hyperplasia. This distinction is important because adenomas respond to surgery, whereas hyperplasia is treated medically. This is the difference there, students. Difference between the bilateral adrenal hyperplasia or the adrenal adenoma. When there is an adrenal adenoma that affects the life of the patient, so complain from hypersecretion, it is uncontrolled by medical treatment, so it needs surgical removal of this adenoma or surgical removal of all the gland. But when we have a bilateral adrenal hyperplasia, we may control it by medical treatment, and if failed, then may go for surgery. Clinical feature: hypertension is a central feature of the disease. Other symptoms are non-specific and may include polyuria, nocturia, proximal muscle weakness, and headache. The biochemical feature of the primary aldosteronism: hypokalemia, high plasma aldosterone, low plasma renin activity, metabolic alkalosis. ليش هذا يصير عندنا شباب؟ Because we are under the other effect or control by system of renin angiotensin aldosterone system. Screen for the disease: hypertensive patient with spontaneous hypokalemia, moderately severe hypokalemia after conventional diuretic therapy, refractory hypertension. How is the diagnosis confirmed? The best way to confirm the diagnosis of primary aldosteronism is to demonstrate suppressible aldosterone secretion during prolonged salt retention. Repletion, sorry. During prolonged salt repletion. The localization procedure. Now we will go for diagnosis by either the start with the investigation by radiological modality. So start by CT scan of the adrenals, bilaterally enlarged adrenals suggest hyperplasia, and then go for the scintigraphy and renal vein sampling for aldosterone. Okay, it is very important for localization of the tumor. So we do CT scan or do MRI and then go for scintigraphy, and also very important to selective renal adrenal vein sampling. Selective adrenal vein sampling. Okay. Indication for surgery: primary aldosteronism, unilateral adenoma, spironolactone is used to treat primary aldosteronism medically. Okay, now medically starts with treatment of primary aldosteronism by spironolactone. The function of the spironolactone, it is diuretic, potassium sparing diuretics. It is a potassium sparing diuretics. Now we will go for the other disease. It is the pheochromocytoma. Pheochromocytoma. Pheochromocytoma is a tumor derived from chromaffin cells that is associated with pathological secretion of catecholamine. As I said previously, the adrenal medulla secrete the catecholamine. It is the epinephrine or epinephrine, norepinephrine, or adrenaline, the same thing, the adrenaline, noradrenaline, or epinephrine, norepinephrine. It is secreted from chromaffin cells from the adrenal medulla. As you know, the epinephrine or norepinephrine is very important for controlling the blood pressure, and its secretion affected by the function and the disease, the adenoma or the carcinoma that affect the adrenal medulla. Location: about 90% are located in the adrenal gland. Okay. Sometimes there is an extra adrenal tumor. 10% only represent that. Most extra adrenal pheochromocytoma are associated with symptomatic ganglia in the retroperitoneum. Okay, there, student. Okay, two type, 90%. It is very important from the adrenal adenoma. So when the patient come complain from pheochromocytoma, we should at first start by investigation for the adrenal cause, because 90% of that come from the adrenal gland. But sometimes there is a large ganglion or sympathetic ganglion in the retroperitoneal region may secrete the or cause the sign and symptom of the pheochromocytoma. Now go for the rule of 10. Rule of 10 for the pheochromocytoma. 10% of the tumor are extraadrenal. This is the characteristic feature of the pheochromocytoma. It's the characteristic feature. Let's say the rule of 10. Rule of 10. 10% extraadrenal, 10% malignant, 10% associated with multiple endocrine neoplasia syndrome. I mean by this, MEN. It is multiple endocrine neoplasia syndrome. Multiple endocrine neoplasia syndrome. And also 10% bilateral and 10% pediatric. It is called the rules of 10. The rule of 10. Okay. Symptom. The symptoms are those of excessive catecholamine secretion and include the classic triad of headache, sweating, and palpitation. This is the triad for pheochromocytoma. Very important there, students. When in the exam come This is the key for the case. Triad of headache, sweating, and palpitation. Something like the triad of the pyelonephritis. It is the pain, loin pain, fever, rigor. Okay. Now, in the case of the pheochromocytoma, the triad, it is headache, sweating, and palpitation. Headache, sweating, and palpitation. Pheochromocytoma, however, can present with various non-specific symptoms and include tremors, nausea, dyspnea, fatigue, dizziness, and chest and abdominal pain. Okay, now physical findings. Hypertension, most common, which may be sustained or paroxysmal. So, very important sign, it is the hypertension, or say it is non-treatable hypertension. Hypertension, most common, occurs sustained type of hypertension, but sometimes it can paroxysmal. Signs of catecholamine excess include tachycardia, tremor, and Raynaud's phenomenon. Who should be evaluated? Who should be evaluated? Priority for evaluation should be given to patients with headache, sweating, and palpitations, incidental adrenal mass, hypertensive crisis with surgery, anesthesia, or parturition. Family history of pheochromocytoma. So screen for the family. Screen for the family with pheochromocytoma. So those patients with pheochromocytoma, especially with family history or patients with history of pheochromocytoma and also on treatment, when they undergo surgery, we should do screen for him and evaluated for him, because there is an hypertensive crisis during surgery and anesthesia. Localization of the pheochromocytoma. CT scan of the abdomen or pelvis. MRI. Magnetic resonance imaging. Meta-iodo benzyl guanidine, MIBG, very important. Meta-iodo benzyl guanidine. Now, go for the preoperative regime or preoperative preparation for the patient with pheochromocytoma. The goal of preoperative management to prevent the cardiovascular morbidity due to severe hypertension. The standard medical preparation should be to treat the patient with the non-selective alpha adrenergic blocker, phenoxybenzamine, for 4 weeks before surgery. Beta blocker drugs are used to control the cardiac arrhythmias. In these cases, alpha block should be in the placed first to avoid paradoxical hypertensive crisis. شو الفائدة من هذا الموضوع؟ Preoperative preparation as I said previously, the patient may have a hypertensive crisis before surgery or during surgery with induction of anesthesia. So to avoid this condition, we should prepare the patient by about 3 to 4 weeks before surgery by starting alpha blocker and then by beta blocker. The benefit from the alpha blocker is to avoid the hypertensive crisis, and the beta blocker to decrease the incidence of a cardiac arrhythmia. So it is very important to put in your mind the patient before surgery need a preparation to avoid this crisis that may occur during operation. In addition to medication, many of these patients are volume depleted and require vigorous intravenous hydration the day before surgery. Okay. Now we will go for the neuroblastoma. Neuroblastoma, the most common extracranial solid tumor of childhood. This is the character of this tumor. Most common extracranial solid tumor of childhood. 80% of children are diagnosed at age less than 4 years. This tumor, please, dear student, I now should inform you about there is a two type of retroperitoneal. There is two type of the retroperitoneal tumor in pediatric age group. It is the neuroblastoma and nephroblastoma. Now we will say about the neuroblastoma and the nephroblastoma. We'll get it in the tumor of renal tumors. In the previous lecture, we will give you a lecture about the renal tumors. We said in the pediatric age group there is a Wilms tumor. Okay, you remember Wilms tumor? So Wilms tumor, it is the nephroblastoma, but now we'll get the neuroblastoma. Nearly the presentation same. The patient complained from retroperitoneal mass, and we said when the mother tried to address the baby, or change his clothes, or during bathing, she come and said her baby complained from a mass in the retroperitoneum, or sorry, in a mass in the flank. So we should put in our mind there are two types of the mass in the flank, either in the pediatric age group. It is the neuroblastoma and nephroblastoma. Nephroblastoma is a Wilms tumor. Neuroblastoma, it is the tumor of the or it is a solid tumor of childhood. Okay, 80% of children are diagnosed at age less than 4 years of age. These tumors are of neural crest cell origin and can occur anywhere in the neuro ectoderm chain. Approximately 50% arise in the adrenal medulla, and most of other occur along the sympathetic chain. So it is of neural crest origin, or neuroectoderm chain. When there is an area for neuroectoderm extension, it may occur neuroblastoma. So it may occur in the adrenal medulla or may occur in the sympathetic chain or sympathetic ganglia. Okay, presentation, very important. Non-specific, like fever, abdominal pain, abdominal mass, weight loss, anemia, bone pain, and or proptosis and prior bilateral ecchymosis, and also neuroblastoma also presents on prenatal ultrasonography. Now it is the difference between the if the exam come case to you or there is a question about this, the patient with a baby with retroperitoneal tumor, if have fever, abdominal pain, mass, weight loss, anemia, bone pain, all of this go with neuroblastoma, because the patient with a neuroblastoma not come with this symptom. Most of the time, the patient comes symptomless, only mass. The patient with nephroblastoma come only with sign of mass, but and the patient with neuroblastoma complain from fever, weight loss, bone pain, proptosis, ecchymosis sometime. Okay, so it is very important to differentiate them. Now we will go for the staging system for neuroblastoma. It is very important because according to the staging system, the management depend. Stage 1, a tumor confined to organ of origin with a grossly complete excision. Okay, stage 1, a tumor confined to an organ of origin. Stage 2A, unilateral tumor with the gross residual after resection. We do surgery, do resection, and gross residual after resection. Stage 2B, unilateral tumor with positive ipsilateral lymph nodes. Okay, then stage 2B بقى عندنا lymph node. Stage 3, tumor crossing the midline or positive contralateral lymph node. Tumor crossing the midline or positive contralateral lymph node. Stage 4, metastatic disease beyond regional lymph node. And stage 4S, unilateral tumor with or without positive ipsilateral lymph node with metastatic disease limited to the liver, skin, and or bone marrow. Okay, if you see the stage 5, you see there is a metastasis of the disease for different type of the body, but this type is a unique and have a unique expression of metastatic neuroblastoma. Patients are generally less than 1 year of age and have localized primary tumor, as well as metastasis limited to the liver, skin, bone marrow. These tumors have tendency to resolve with little or no treatment. Okay, there, but you're in your mind شوف هذا ستيج 4 كأنه الستيج 4S كأنه فد aggressive and highly extended tumor but على العكس انه البيشنت with this stage 4 stage 4S at first you find a primary localized tumor and there is a metastasis for the specific organ, the liver, the bone marrow, but this in spite of this tumor may have a tendency to resolve either without a tumor treatment, or with some sort of treatment. Subhanallah. Okay. Now, urinary catecholamine metabolite measured in addition to retrographic, radiographic evaluation of all patients undergo 24-hour urine collection for measurement of catecholamine metabolite. Urinary homovanillic acid HMA and or vinyl mandelic acid VMA level are evaluated in more than 90% with neuroblastoma. This is I add this modality for diagnosis for your knowledge, dear student. So sometimes you see your senior write this type of investigation for patients with to find the neuroblastoma. So the metabolite of the catecholamine secreted in urine, and we sometimes do 24-hour collection of urine for to measure the catecholamine metabolite. Well, investigation that presents two types of investigation: VMA, vanillic acid, or homovanillic acid. Both of them, it is the worst product or metabolite of the catecholamine. Okay. Now, what I mean by MIBG scan. قلنا الميتا ايودو بنزيل guanidine is an amine precursor that is concentrated in the neuroblastoma and other neuroendocrine tumor. Meta iodobenzene guanidine scan are very sensitive for detecting the neuroblastoma. Okay. Now we go for the treatment. Patients with low stage favorable tumor have been treated with surgical excision alone. Okay. هسه اجينا شنو الفائده من سوينا staging؟ ليش سوينا هذا الستيجنج سيستم؟ قلت لكم راح نستفاد من عنده بالمانجمنت، مو صحيح؟ فالبيشنت with favorable tumor with low stage favorable tumors may be treated by surgical excision alone. نجي نسوي surgical removal of this tumor and that's all. It is if favorable tumor stage 1 and stage 2A. Stage 2B and else patient with high risk tumor require adjuvant multi-agent chemotherapy and sometimes radiotherapy as well. You know what I mean by adjuvant? Adjuvant, we should start if the patient come with non-favorable tumor, can same thing like that in the nephroblastoma, something like the nephroblastoma. Okay, تذكروها بالمحاضرة انطيناها nephroblastoma دكتور. nephroblastoma, if the patient have non-favorable tumor, we should start by chemo-radio. Try to get rid of the size of the tumor and then go for surgery. Same things here. Either start by adjuvant or new adjuvant treatment. Adjuvant treatment. Adjuvant treatment may need, after the resection of the tumor, treat the patient either by chemotherapy or radiotherapy. That's all for today. If anyone have any question there.
دكتور الفيوكروموسايتوما دائما تكون بناين لو بيها malignant potential.
لا مو شرط. According to type of a tumor. Benign or malignant. Pheochromocytoma is the sign and symptom of the tumor of the secreted substance from this nodule. But this nodule may be malignant or benign. Okay. Other one, please. Answer me. If we have a 4-year-old baby presented to you, complain from failure to thrive, abdominal pain, repeated vomiting, and the mother said that he complained from a flank bulging that increase with time, and presented to you. How you start the follow-up of this patient or this baby? Anyone, please? Anyone there?
هو هاي الساين وش سيمتوم مال النيوروبلاستوما.
Maybe. Okay, so how you start? Very good. Start follow up.
يعني
نبدأ اثنين، لربما نيورو ولربما نفرو، مو صحيح؟
نعم.
احنا صح، احنا قلنا بالسؤال اكو عندنا كي ونتبع الكي ونحل الكيس. صحيح، كلامك جدا صحيح، ولكنه خلينا نخلي ببالنا لربما نفروبلاستوما، مو صحيح؟ اذن فاحنا لازم شو نسوي؟ نسوي انفستيجيشن المطلوبه، مو صحيح؟ اوكي، ايش راح تسوي له؟
سوي الميتابولايت مال الكاتيكونامين فانيلايل ماندريك اسيد.
فيري جود. وبعد؟ فيري جود، صحيح كلامك صحيح. احنا نقول نبدي بالانفستيجيشن مالتنا. مو اول شيء الايمجنج تكنيك، نسوي سي تي سكان، طلع عندنا اكو ماس. احنا هي الام صحيح قالت اكو ماس، بس احنا حتى نحل الكيس ويصير جوابنا صحيح نبدي هيستوري اكزامينيشن. مو صحيح شباب؟ بعدين نبدي انفستيجيشن، والانفستيجيشن لازم ستارت وذ سمبل انفستيجيشن اللي هي سمبل وافيلبل ونوت كوستلي ونوت انفيزيف. مو صحيح؟ بعدين حتى يصير جوابنا مرتب بالامتحان ان شاء الله. اوكي، very good, very good. Now 30 years old female presented complaint from increased weight, central obesity, shiny face, multiple acne in face, and she complained from striae, abdominal striae. You measure the blood pressure, find it about 180/110. And complain from easy ecchymosis with simple trauma. Now, how you can deal with this patient? Yes, there. Yes, please.
دكتور يعني كدايجنوسيس تكون فيوكروموسايتوما، على أساس إنه هي هسه كوشنج سيندروم، فاحتمال يكون عندها الكورتيزول صاعد.
زين. اوكي كوشن سيندروم. يعني احنا نشوف. اوكي فيري جود. ايش راح تسوي انت؟ اوكي فولو ذا كيس. اوكي
يعني بالبداية هو حتى نأكد دايجنوسيس ناخذ هيستوري زين، إنه هي هل كانت تاخذ ستيرويدز ولا لا.
فيري جود. نسأل اكو عندنا اكسترنال. اوكي فيري جود صح. تعرف يعني اغلب الفيميل وحده قالت لها جيرانهم انطتها حبايه مدري شنو، تعودت انه تاخذ الستيرويد اكزوجينوس ستيرويد. صحيح فيري جود. زين. فاحنا لازم ناخذ هيستوري هنا، نجي عندنا فائده للديتيلد هيستوري. فيري جود صح. بعد ايش راح نسوي؟
اذا يعني كونفيرمد انه هي مثلا ما ماخذه اكسترنال ستيرويد، نروح ناخذ MRI للادرينال جلاند. اذا لقينا فد ماس انه تاكد لنا انه اكو فد تيومر يسبب لنا انكريز مثلا كورتيكوستيرويد سكريشن، يعني هنا ممكن يكون كوشنج سيندروم. اخر احتمال ممكن يكون بتويتر جلاند تيومر، انه يسبب لنا همين increase corticosteroid secretion from adrenal gland.
عفوا اسمك عمو؟ اسمك حبيبي؟
مقتدى نعيم.
حبيبي very good. شباب احنا بس يعني اقول لكم اذكركم على شغله. اكو عندنا هو اكو عندنا رنين انجيوتنسين الدوستيرون سيستم، مو صح؟ حتى نربط بالمحاضره مالتنا مالت الرينال تيومر. اكو عندنا رنينوما، مو تذكرون اخذنا رنينوما لو لا؟ اللي هو قلنا سمول تيومر او ذي رينال، مو صح لو لا؟ مالت الرنين سكريشن، تتذكروها شباب؟ فاحنا عندنا رنين انجيوتنسين الدوستيرون سيستم كنترول the blood pressure و control the flow of blood to the kidney، مو صحيح؟ فعندنا الرنين هو من الكدني، والالدوستيرون من يجينا؟ من الادرينال جلاند. هو المينرالا كورتيكويد. اوكي شباب؟ والمينرالا كورتيكويد. فاحنا جلوكوكورتيكويد هو الكورتيزول، مينرالا كورتيكويد اللي هو الالدوستيرون، والسكس هرمون or the الاندروجين. اوكي شباب؟ very good. Thank you for and if you have any question please. Any question please.
دكتور الكوشنج سيندروم اذا كانت من بتويتري اوريجن او ادرينال اوريجن، اقدر افرق بينهم من الكلينيكال ساينز لو بس بالايميجينج؟
لا ايميجينج.
شكرا
جزيلا شباب. شكرا.